Hello everybody and welcome to this webinar on interpreting renal biochemistry. Part 2 of this series will be on the 10th of April, and in that webinar we'll be looking at key medicines in paediatric kidney disease, but today we're going to be looking at renal biochemistry. Just to say that the webinar is intended for healthcare professionals only, and it will last about 60 minutes and we'll have time for questions and answers within that hour. Remember to submit your questions at any time during the webinar, and you can do this by looking at the question box on your screen and putting your answers there at any time during the presentation. A certificate of attendance will be provided via email at the end of the webinar. And just to remind you, if you wish to see this webinar again, it will be recorded and it will appear on the VitaFlow website in a few weeks' time. Just to say that financial support for this presentation was provided by VitaFlow, but that the views expressed in this webinar are those of the presenters and they don't necessarily represent VitaFlow's views, and that any material that you hear and see today is accurate today, i.e. on the date that it's presented. So the learning objectives for today, at the end of the webinar, we hope you'll be able to interpret biochemistry for patients with kidney disease, and that you'll be able to apply biochemistry to evaluate the nutritional needs of patients with kidney disease. And so now it's my great pleasure to introduce our speaker for today, Dr. Evelien Snauwaert, who's a consultant paediatric nephrologist at Ghent University Hospital, Belgium. Evelien obtained her diploma in paediatric nephrology in 2017 in Paris and pursued her paediatric nephrology fellowship at both Ghent University Hospital and at the Hospital for Sick Children in Toronto. Evelien's interests and indeed passions are chronic kidney disease and dialysis, and she's been a member of the Paediatric Renal Nutrition Task Force since 2021, and we've been really pleased to have her expertise on this task force. Just a quick word about me so you know who I am. I'm an honorary senior lecturer at UCL Great Ormond Street Institute of Child's Health, and that's in London. And up until 2017, I was the head of dietetics at Great Ormond Street Hospital for Children, where obviously my clinical speciality was paediatric nephrology. I'm a founder member of the Paediatric Renal Nutrition Task Force. And so now I would like to hand over to Evelien, who I'm sure will give us an excellent presentation. Remember to post your questions to us during the course of her talk, and there will be an opportunity to have a Q&A session at the end. So, Evelien, over to you.
Thank you very much, Vanessa, for this kind introduction. So indeed, I will talk about biochemistry in the pediatric chronic kidney disease population. And I've divided my talk in 5 pieces for today. I think to really understand what the biochemistry means, I think we have to really start from the beginning and understand what the general principles of kidney functions are, and that's where I'm going to start. So the healthy kidney is responsible for different functions. The first one, they are responsible to remove waste products in the blood. Second, they are responsible for the homeostasis of fluid, electrolytes, and acid base. And third, they play an important role in several hormonal systems, for instance, calcium, phosphate, and vitamin D metabolism, hemoglobin levels, and blood pressure control. When kidney functions are deteriorating, then you see problems in these different functions. You will have an accumulation of waste products in the body, of which many of them are toxic to the body and are called uremic toxins. You will have dysregulation of fluid, electrolytes, and acid bases presented by electrolyte disorders, edema, hypertension, and so on. And of course, you will have also these disruptions in hormonal function. You will get anemia, blood pressure problems like hypertension, and bone disease. It's, of course, not a surprise to you that when the kidneys are failing, then this will have an impact on all organ systems in the body. You will have a systemic disease. Most prominent cardiovascular disease is very common in this disease population. These children have growth failure and delayed puberty, have muscle wasting, and several others. While in the beginning, in the earliest stages of CKD, the disease is often asymptomatic. You see that with the duration of kidney functions, that symptoms will occur until at the very end stage, you will see that patients will have very severe failure to thrive, fatigue, and poorly controlled electrolytes and edema. And this is the period where dialysis and kidney transplantation is needed. Chronic kidney disease in children is rare, and it's mainly due to congenital disease of kidney and urinary tract disorders. Of course, these are the types of kidney replacement therapy where, of course, in children, we prefer the kidney transplant where possible. So this is a very short introduction. I will go now to the first most important biochemistry measures that we have in our kidney disease assessment. And these are mainly the basis of our definitions of chronic kidney disease. If you look to the KDIGO guidelines updated 2017 on how chronic kidney disease is defined, then we see that central is the abnormality in kidney structure and function that is already there for more than 3 months with implication in health. But then they will use two very crucial biochemistry measures, which are glomerular filtration rate or GFR, and also albuminuria, depending on the degree of kidney impairment, so the degree of GFR loss and the amount of proteinuria, the prognosis of the CKD disease is made. Let's dive a little bit more in detail on the urine analysis. Well, in the past, 24-hour urine collections were used more often. We currently, especially in children, are using especially the urine samples, just on a spot sample. If we have a first morning sample, then this is the most reliable one to quantify proteinuria. And we also always are going to express proteinuria related to the creatinine concentration in the urine to correct the proteinuria levels for the concentration degree of the urine sample. The amount of proteinuria is, as I said before, very important in terms of prognosis, where you see that especially those patients with the higher degree of proteinuria will have the fastest deterioration of kidney function. Second parameter that we are using in definition is GFR. GFR is the most used measure of renal functional capacity, and it really reflects quite well the number of functional nephrons in this patient. It's defined as a volume of plasma that can be cleared of an ideal substances per unit of time, and it's corrected also for body surface area. We often typically are going to express this as ml per minute per 1.73 square meter. The gold standard to measure GFR is using a prototype ideal substance like inulin, iohexol, or chrome EDTA. But of course, in practice, where you will have to sample after administration of this product over time, it's not a very easy measure to do in practice. And that's also why we are currently using endogenous produced substrates like creatinine and cystatin C to estimate GFR in our clinical practice. Important in the pediatric population is, of course, that GFR is changing according to age. At birth, GFR is quite low, and you see a steadily increase throughout the first 2 years of age. And then from the age of 2, you have the same values as in adults. To give you a bit more numbers about the GFR references, I've put them here with also the references here, where you see that, for instance, a premature born baby of 27 weeks gestation will have only GFR at day 7 around 10, where you see that a child of the age of 1 will have around 60 to 120 mL per minute per 1.73 square meter. To calculate, which of course we're doing most in practice, the estimated GFR, then we are using two substances most commonly, creatinine and cystatin C. Creatinine is, of course, standardly used and most commonly used in most centers. It's the measure with the lowest cost as well. And creatinine is a waste product of skeletal muscle, and it's produced at a very steady production rate. Of course, the fact that it's produced from the muscle itself makes that it's related to the muscle mass, the body surface area of a patient, the height. And you will see that also in adults, that males will have high creatinine levels in comparison with females. This, of course, gives some side It's not ideal in the populations to use creatinine in those groups where you have malnutrition, those patients who are sporting quite extreme, those who have an amputation in the past, those who had special diets like ketogenic diet, or have muscle wasting because of steroids of chronic disease. In these circumstances, cystatin C is more reliable. Cystatin C is a low molecular weight protein that is produced by all cells, and it's not that related to body mass or of body size. If you look on the internet, you have quite some instances who are providing you with good calculators to estimate GFR, where you always will need or serum creatinine or serum cystatin C, the height of the patient and the sex. You have most easy formula is a bedside Schwartz, but you also have the more updated CKD cohort calculator published recently that is also providing you both with cystatin C as creatinine-based GFR estimations. I will go now for a quick case to more illustrate this in practice. So the first case I've presented is a girl of 15 months with steroid-resistant nephrotic syndrome. Her genetics revealed a pathogenic missense variant, 2 variants in podocin, which is showing you a genetic form of nephrotic syndrome. She's been very challenging to treat. She's been admitted already for more than 4 weeks in the hospital because she's needing very regular albumin infusions, and she's also treated with high doses steroids for a long time. Here you have the lab results from her at point of assessment. You can see her urea level is 48, her creatinine is 0.48. You also see her low albumin, which is of course related to her underlying disease. And I also added here the cystatin C levels. And I've already calculated for your, to make it a bit more easier for you, the GFR based on creatinine and on cystatin C. My question to you, and you will have a poll to answer the question, is which treatment is wrong? So the first statement is a child with malnutrition and long-term immobilization and significant renal dysfunction may still have a plasma creatinine level within the reference interval, correct or not? 2, the child presented here is a child who suffers probably from muscle wasting. 3, creatinine is a more appropriate endogenous marker than cystatin C to estimate GFR in this patient. And then 4, the child is classified according to KDIGO as stage 3B and A3 for the proteinuria. I invite you to vote, and I will give you just a little bit of time before I close this question. You can see everyone voting. I will give you just a little bit more time. If everyone is okay, then I'll maybe close this poll. I think the majority has been answering very correct. So indeed, creatinine here is not the best measure to use. As you can see here in the results of the eGFR, you see that there's a very big difference between cystatin C and creatinine-based formulas. I think this is especially a patient that a cystatin C can give you a little bit more information. Again, I'm not arguing you here to perform cystatin C every time. You can do it once in a while just to have the evolution over time, and you can use creatinine on a day-to-day basis to follow up the trends over time. But if you really want to have an idea about how significant is this kidney impairment, then cystatin C is here definitely an added value. The fact that the creatinine here is so low is just probably reflecting the story here: long-term steroids, immobilization, and muscle wasting. Okay, let's move on. So for the rest of my talk, I have classified the biochemistry related to the functions of the kidney. So I will start with the accumulation of waste products and uremic toxins. So when the kidney function is deteriorating, you will have an accumulation of different waste products in the blood, but many of them having toxic effects. They are typically categorized in 3 groups depending on how they behave during dialysis. So the first group are the water-soluble molecules. These are typical molecules who are very easily removed with dialysis, and the one that is most often used in our practice is urea, is one of this group. The second group are the middle molecules. These are bigger molecules and not with all techniques, dialysis techniques removed, especially with the convection, you can remove these molecules. And these is, for example, beta-2 microglobulin, PTH, and so on. And then the last group are the uremic toxins who are protein bound. They are also small, like the small water solutes, but they are bound to albumin, which make them currently quite difficult to remove. The most common example is indoxyl sulfate. These uremic toxins, they have been related to many comorbidities in CKD. They have been linked to cardiovascular disease, inflammation, oxidative stress, and so on. Nevertheless, there are many of them, and we don't use them in clinical practice to measure. The only one that we are using is urea, but just keep in mind, of course, that this uremic toxin is not behaving like different others. So it's only a fraction of the solids who are accumulating in children with chronic kidney disease. Indirectly, you can also appreciate the fact that these solids are accumulating if you look to the anion gap, the presence of metabolic acidosis, because then you also see that the high anion gap is reflected by the accumulation of endogenous acids who occur when the kidney is not able to excrete these acids in sufficient quantities. So I will go on to the second case. So now I have a case of a boy of 2 years old who has been on chronic hemodialysis since 6 months. He got bilateral nephrectomies because of nephroblastoma, intractable and not responsive to chemotherapy 6 months ago. And the dietitian was consulted because of poor weight gain. I think you can see this very clearly in the growth chart, where you see that the weight is really stable in the last months. Here is a lab results of this patient at the time that they ask your consult. So you see that the electrolytes are nicely controlled. Urea is 40, creatinine is 4. So my question to you is, which statement is wrong? A normal serum urea, or BUN, in children with kidney failure is indicative for a poor dietary protein intake, yes or no? 2, a poor dietary intake is very likely in this patient. 3, a prospective 3-day diet history or a diet recall over a 24-hour period is needed to obtain a comprehensive information on dietary intake. And the last one, serum albumin is a nutritional marker with high sensitivity and specificity. I'll give you again some time to read, and then you can start voting. Normally on the right, you will have the poll coming up. Give a little bit more time before ending this poll. So I see that 76% of the participants are giving indeed the correct answer. So it's indeed the last statement that is wrong. Let me just go through them. The first statement is correct. So, and this is what is happening in this patient. This patient has a too low urea for the state of kidney disease. The fact that it's so low is very indicative for a poor protein intake here in this patient, and it's really a point of attention that is needed here. Serum albumin is a marker that can that tells you something about nutritional as a nutritional marker, but it's definitely not one with a high sensitivity and specificity. The reason why is that serum albumin is also influenced by many other factors who are not related to nutrition, like inflammation, infection, and fluid overload, and therefore is not reliable to use in our daily practice. So let's move on. I will go now to the hormonal functions of the kidney, and I will mainly focus on anemia and also chronic kidney disease, minimal bone disease as well. So let's first start with anemia. Anemia is one of the most common complications of CKD in children, and it's associated with a very high risk for hospitalization, mortality, and cardiovascular disease. If you look to the prevalences, it's a comorbidity that is almost present in the majority of the children with CKD stage 5, but also in CKD stage 3, you see that 3/4 of the patients already suffer from anemia. To really be able to diagnose and interpret hemoglobin levels, keep in mind that these reference values are related to age, where you see that in the young children, the cutoff is 11 for hemoglobin, where in the older children, it will be 12 in the females and 13 in the males. The reason why patients are developing anemia is multifactorial in chronic kidney disease. There is on one hand, of course, a deficiency in the production or regulation of erythropoietin. There's also a factor iron deficiency who is contributing there. Inflammation is also an important factor there, as well as chronic blood loss, uremia, oxidative stress, but also nutritional deficiencies like vitamin B12, folate, and so on. If you look to the big groups of factors who are contributing to anemia, who are also relevant in terms of nutritional management, I think the first one is iron deficiency. Second one, the vitamin B12 and folate deficiency. And then, of course, the factor is chronic disease, inflammation related. Depending on the results then of your lab, you can really make a distinguish between these two entities and also decide which your treatment actions will be. For instance, if you look to iron deficiency, then you will have very typically a low mean corporal volume in MCV. While you see that in vitamin B12, you will have especially high MCV value. Same low ferritin values are reflecting a low iron store, and also a lower T-sat or transferrin saturation is also indicative for an iron supplementation anemia and would put us as least in favor to start the supplementation of iron. In the setting of chronic inflammation, then you see that MCV are often normal or slightly decreased, and also ferritins are normal up to higher. And then in this case, erythropoietin stimulating agents are a better choice to go for. But in CKD, it's often multifactorial. It's often are different actions needed. And it's not uncommon, especially in the end-stage kidney disease, to have both an iron supplementation there and an erythropoiesis stimulating agent as well. Okay, so I will move on to the mineral bone disease. Mineral bone disease is a systemic disorder who is encompassing abnormalities in calcium, phosphorus, PTH, vitamin D metabolism, and is also associated with abnormalities in bone histology and skeletal, extraskeletal calcification. If you look to the course of CKD, then you see that calcium levels are often stable throughout the different stages of CKD. While you see that PTH levels are early on increasing from CKD stage 3 and are going exponentially at the end of kidney failure. Phosphate levels are often maintained also for a longer time and within the normal range, mainly due to FGF23, who rises earlier. For the treatment or the assessment of this biochemistry results of calcium, phosphorus, PTH, and vitamin D, I think the most important thing to keep in mind is that you always will base your therapeutic decisions on the trends from the individual measures over time, and you will never base the decision only on only one single laboratory value. You always have to look to the trends and also look to the trends of all the individual parameters related to CKD and BD. I think overall we can say that an elevated phosphate level should be normalized within the normal range, and that we in children are really strongly suggesting and that we maintain serum calcium levels within the age-appropriate normal range. If there is vitamin deficiency or insufficiency, then we of course will correct that. And of course, the most difficult part is the PTH targets. What is really the optimal PTH target is not really known. In these children who are not on dialysis, I think it's really important to look to these patients who have a progressively rising PTH levels and see which factor you can modify. Is there high phosphate? Okay, then we react on that. Is it calcium levels low? Then of course we will react on that. Is there vitamin deficiency? Yes or no? And these are the things that we will always reassess depending on how the PTH is trending and over time. For children on dialysis, we'll use different PTH targets where we allow higher PTH levels between 2 to 9 times the normal limits of normal. But there again, you will look to the modifier factors, what is the phosphate levels, which is serum calcium levels, and so on. To illustrate you that, I also have prepared 2 cases, which I think really highlights a bit how we tackle this on a day-to-day basis. So the first case is a girl of 13 who is on chronic hemodialysis. Her routine labs reveal a rising PTH. So you see here PTH, so month 1, month 2, month 3. So you see the trend. You see that it's 3 times higher in the last control. And my question to you is, after seeing these lab results over time, which of these approaches is wrong? First, in case adherence to current dietary intake of phosphate is adequate, I could propose to add a phosphine binder here. 2, an assessment of dietary intake of phosphate and adherence to phosphine binders is recommended in this patient. 3, to decrease serum phosphate levels, we recommend to optimize phosphate removal during dialysis, for instance, increasing blood flow and so on. Or 4, you think at this point, this is still what I expect in this patient and no action is needed at this point. Happy to hear what you think. Normally you can already start voting for this case, and I'm happy to hear what you think. Just take some time to look to the individual lab results, and I've also put the reference values in the last column that you can also consider these as well, because of course we all use different reference values as well. Give you again some time. Questions are too easy, I think. I think, again, 3/4 of the people are right here in the room. So if it's indeed the last option is wrong. The problem here is indeed your phosphate. You see, although the PTH is increasing but not that high, but you see that the phosphate levels is definitely high. You have already 2 times a very high phosphate. So I think this is a moment to really talk with your patients to see, okay, are they taking the binders? Are they taking them in the correct way? What is phosphate intake? Is something changed? Yes or no? And if there's still room in your dialysis regimen to increase your adequacy, your phosphate removal, you already can think about that. You don't have to wait until your PTH is like up to the 500-600s there. So my approach would be to really already start thinking about his phosphate levels. Okay, I have a second patient here. So this is a boy of 10 with CKD stage 4. He's not on dialysis, and his routine labs reveal a rising PTH. And here the same question, which statement is wrong? And I think normally the poll will come open, and I'll give you some time to look to the values and to decide what to do. the options I provide you is first, an assessment of dietary intake of calcium is not needed. 2, in case insufficient dietary calcium intake is present, we recommend to optimize calcium intake from diet and medication to the SDI. 3, calcitriol and vitamin D analogs may be considered to maintain serum calcium levels in the age-appropriate normal range. And then 4, this patient presents here with a high PTH with low normal calcium and normal phosphate levels. Start voting now. Time. Easy. So everyone is correct. The majority is correct again. 78% is giving you the correct answer. So it's indeed the first option who is not correct. Here you see again a rise in PTH is still minor, but it's definitely present. But you see that the serum calcium levels are low normal. So the two things that always go through my mind if you have a normal phosphate level is, of course, is the calcium intake normal? And then, of course, that's something that has to be assessed. And here, an vitamin D analog or calcitriol would be a good option to consider to increase your serum calcium and therefore also decrease PTH. Remind here, we have a patient who is CKD stage 4. So here we are more strict in our PTH targets and often go lower. But I think it's most important to look to your phosphate and calcium here as well. The native vitamin D reserves are here quite well, around the 30. So that seems to be fine. Yes, so I think I hope with these two cases, I can show you that we really have to focus on trends. You don't look to one value, you just look to the several measures in the last months. And for children, you have to use the age-appropriate reference values in children. I've put them also here in the slides for your references. Same here, also your calcium intake and phosphate intake is also related to age. These are also present here on the slide. And I've put here also some of the references who are, I think, very good guidelines to read, to further understand how to deal with CKD and BD in children. Okay, and then I will move to the last big group of problems that we see in our patients. So potassium. A normal range of serum potassium is between 3.5 and 5 millimole per liter. And we are talking about hyperkalemia from more than 5 in children. And in neonates, we're a little bit more tolerant. It's from more than 5.5 millimoles per liter. Hypokalemia is defined as a potassium level below 3.5. It's important to consider when talking about potassium is that more than 98% of the total potassium in our body is intracellularly. So what we are seeing in our blood sampling is only a fraction of the potassium that is present in the body. So that's also why that when you have acute changes, it's mostly related to the shifts that happen between the inter and the extracellular compartments. In chronic elevated potassium levels, then you see that it's more reflecting the total potassium quantity in these patients. When sampling is happening in our patients, the most important thing to consider always before acting and deciding what to do is, of course, that we often see an pseudo-hyperkalemia in our patients. This is a high potassium who is caused by the movement of potassium out of the cells through the blood taking process, which is mainly in children due to hemolysis. In these patients, then you will have on paper a high potassium, but it's not really affecting what is happening in the patients. Of course, it's important always to think about in this difficult population that if this potassium is true or not. If it can be true, you have to react quickly because an hyperkalemia can be very severe and can have also fatal cardiac arrhythmias as well. So it's always an urgency. If the hyperkalemia is severe, we have to always act quickly. Of course, hyperkalemia, it's in CKD quite common. We see it very often, especially in those patients with more advanced stages of CKD. And this is because of the inability of the kidney to excrete potassium, but it's also because of the movement of potassium from intracellular to the extracellular compartment due to metabolic acidosis. And of course, there are also certain drugs like ACE inhibitors, ARBs, who are commonly used in our population, who also will put our patients at risk for hyperkalemia as well. Going then to sodium. Sodium is a more difficult one. Sodium is very closely related to the water homeostasis. You cannot talk about sodium without talking about water. And sodium, in comparison with potassium, is here the main extracellular anion. So changes in plasma volume will always change also the serum concentrations of sodium as well. In clinical practice, the majority of abnormal sodium concentrations are mainly due to changes in water homeostasis rather than sodium. Okay, this is also reflected in our workup, how we will manage sodium levels. In case GFR is normal, you can also look in more detail what is the reason behind by assessing the volume status, by calculating the fraction excretion of sodium in the urine, and also determine plasma and urine osmolarity. However, in the presence of CKD, and especially if the kidney impairment is prominent, this is not that reliable anymore. Anyway, if I think in more general, I think I cannot go in very, very detail, but hypernatremia is often caused by just too little water. Patients who have diarrhea or losing more water than salt will have hypernatremia. Also diuretic use, also patients more with the diabetes insipidus, for instance, have hypernatremia. It's very rare to have it due to too much salt. This is a very rare indication of hypernatremia. For hyponatremia, again, you can also split it in too much water or too little salt. And in CKD, the too much water theory is something that we often see quite common. You can also see it in the settings with low albumin levels, heart failure, polydipsia, and so on. In the presence of too little salt, we can also see it in our population, especially those patients with acute dysplasia and who have a renal salt wasting. Also with patients with prominent GI losses like stoma or cystic fibrosis is also present. I have a case about this sodium values for you as well. So a boy of 11 years with CKD stage 3 due to autosomal recessive Alport syndrome is treated with ACE inhibitors because of proteinuria. He has his routine yearly follow-up at the renal dietitian. And my question to you is, what advice is correct to give to this patient? So he has CKD stage 3, and he's treated with an ACE inhibitor because of proteinuria. What advice is correct? So first, to estimate sodium intake, we recommend measuring serum sodium. Second, we recommend measuring urinary sodium to estimate the sodium balance in children with CKD. Third, 24-hour diet recall or food frequency questionnaire is recommended to identify the main dietary causes of sodium. And then the last option is the first 3 statements are correct. I'm happy to hear what you think is a correct answer. This one is a bit more difficult, I think. Bit more time to vote. Okay. So here we have 42 participants who have voted for option 3, and 52% of the participants have voted for statement 4, so that 1 to 3 is correct. Here it's really option 3. Serum sodium will never, this is a let me say it the other way. This patient is a patient who needs to have an salt intake who is not excessive. You want to start early in these patients, even before hypertension is happening. You want to educate this family early on to avoid the excesses in sodium. And to do that, you don't need serum sodium. It will be normal. Even if you're sampling it, it's not going to change your management. Same with urine sodium levels. You can do it with 24-hour or just on the spot. Both of them, we have decided not to use them in our daily practice because in the context of CKD, they are not reflecting sodium intake. It has been done in the past, but all these measures are all done in healthy adults and are not applicable in the population that we have here. So our advice here, and that will also come in our upcoming sodium guideline, which will be published soon, we have abandoned the use of serum and urinary sodium in the estimation of sodium intake in these patients. The only measure that we propose to use is the 24-hour diet recall or food frequency questionnaire. And if you need more detail, you can also go for a 3-day diary as well. Okay, so then I'll just have a last slide about metabolic acidosis. So metabolic acidosis is a pH in the plasma who is lower than 7.4. An optimal pH is very important for all function of the enzymes in our body, and it's really important to keep this pH as stable as possible. In children with chronic kidney disease, metabolic acidosis is very common, and this is because of the fact that, as I said already in the beginning, the kidney is not able to excrete all these acids sufficiently, and of course also in especially in some types of kidney disease, you also have some bicarbonate loss as well in the urine. The anion gap in CKD patients can be normal, but can also be elevated, as I discussed already in the beginning. And if you have a persistent metabolic acidosis, it is associated with mortality and morbidity in children. It's also associated with poor growth curve. So it's a factor that we also will follow up over time and treat if needed. And most of the time, treatments is done with bicarbonate therapy, which is around 0.5 to 1 mg per kilo per day. And we will titrate our treatment depending on the serum bicarbonate levels as well. Okay, and this brings me to the end of my talk. So I think I just wanted to highlight that chronic kidney disease is a systemic disease with alteration in hormonal function, dysregulation of fluid and electrolytes, and accumulation of uremic toxins. Urinary albumin and GFR are really the two key biochemistry measures that are used to define and classify CKD. Creatinine-based GFR calculators can be used in routine care for pediatric CKD, but in particular circumstances, as I highlighted in the cases here today, cystatin C can be of added value as well. And the CKD morbidities have to be followed over time. And this includes the biochemical markers of anemia, CKD-MBD, and electrolytes, as we discussed them in detail today. And I think this is not only for the calcium phosphate, but it's for all other measures as well. The changes of our treatment should be based on the trends of these values over time, and it should not act on one single measurement. So always look to the trends of these values over time. So this brings me to the end of my talk. I'm more than happy to answer some questions together with Vanessa. Yeah, thank you.
Thank you, Evelien, for that brilliant talk, and you've explained it extremely well, and you've really kept us on the ball with your case studies and asking us to respond to the questions that you posed. So just having a look at some questions that have come in for you. Do you feel there's any role for the dietary management of anemia? It does increase in the intake of iron, B12, folate, for example, have any significant impact, or is it all done through supplementation pharmacologically?
In these patients where you already have anemia, where you have really already a settled anemia, I would propose to go for supplementation. All the way around, I think in these patients who have maybe a normal hemoglobin level still, but you already identify some risk factors. And I think in this setting, you probably also can talk about the dietary management more. But in the fact, when you have really severe anemia, I would go in the first place for supplementation to start with, yes.
Thank you. This one is about albumin. My doctors asked me to increase the child's protein intake when their albumin is low to get it up into the normal range, even if their urea is high, still asking for more protein. Is this possible when CKD in itself is an inflammatory state and low albumin levels are expected? So I guess the question is there any point in increasing protein intake in the view of a very high urea, as you showed in your case study? I think the urea was 40, low albumin. Is there any point advising a higher protein intake?
It's true. So albumin is not a specific, or at least not the only, it should not be the only marker that you have to follow to guide your protein intake, because albumin is indeed influenced by many other factors like chronic infections, inflammation, which is typically, especially in end-stage kidney disease, you can have quite severe inflammation. And then this low albumin is just related to that. Same for patients on dialysis, they can have low albumin just because of fluid overload. And this is then completely unrelated to the protein intake. So I would really recommend not to look only to albumin, but again, look to the trends. If your patient is gaining weight with the protein intake, I would not focus only on the serum albumin levels. I think you have to incorporate all these parameters together and see how they evolve over time. So no, basing only on albumin, I would not recommend to do.
Thank you. A question here about phosphate. Again, it's the balance of diet and medication, I guess. Is it your practice to restrict phosphate early on in CKD to delay the introduction of phosphate binders? So can altering the diet prevent or perhaps delay having to give even more medication?
Yes, I'm definitely in favor, and that's also what we are saying in our nutrition guidelines, is that we really would like to involve a dietitian early in the course of CKD, where I think the dietitian can already provide advice about healthy diet, avoiding these fast foods and excesses of phosphate sources who are not needed to grow, not also for healthy children, that they can already advise these measures already early in the course of CKD. It's the same for sodium intake. If they are not used to drink cola every week, they will not do it in the moment that they really have to restrict in the more advanced stages of CKD. So I think the advice of healthy nutrition should start early. Of course, it's not always feasible in all families. And if you have a persistent high phosphate and you don't see this coming down, then I talk with the patients and I see if it is not possible to really go down. I think you have to hear also the voice of the patient, and if he prefers or she prefers to add a medication, a binder, instead of having more strict dietary restrictions, I think this is something that you always can do together with your patients. I think if you hear their opinion there as well, I think you can also, I think, have more satisfaction and motivation for your patients as well. But I think the dietitians should be involved early. It's easier if we can do it stepwise and not all in once, the moment that the phosphate levels are really high.
And as early as CKD2, CKD3?
Like the patient I presented there with Alports, who had already proteinuria, but otherwise no problems. I think it's already good in this early phase to already talk about sodium, healthy diet. Indirectly, you also will give some advice about phosphate just by saying that you would avoid fast foods. So even without framing it as a phosphate restriction, by giving this healthy advice and stressing how important it is to have healthy food, I think you already can have a good influence already early on. So yes, it doesn't have to be every 3 months, but even once a year in these early stages, I think is definitely of benefit.
Okay, thank you. In the setting of metabolic acidosis, what are some dietary adjustments that you would recommend? Your final slide said the treatment of metabolic acidosis was by giving medicinal bicarbonate. But do you see a future where there might be more dietary management of metabolic acidosis, cutting down animal protein, favouring plant-based protein to get a less acid-producing environment?
Yes, definitely. And you're completely right by pointing this issue. I think it's lacking in my slides, but no, we know that diets who are more plant-based and are having a low amount of animal sources of protein, that they also have the benefit that they are not that acid, and you often can have better control of metabolic acidosis. However, and I think especially in those children with dysplasia who are polyuric, sodium, and often also bicarbonate losers, they will have also often metabolic acidosis early in the course. I'm not sure if you can completely replace the nutritional advice, but yes, I think you definitely can have an added value there to also have some dietary advice as well. Yeah.
Thank you. We often see high vitamin A levels. Is there a difference in the different stages of CKD, and how concerned should we be to see high vitamin A levels?
Yes, it's correct. So I think vitamin A levels, we cannot do anything about it. It's the only thing we can do is prevention and avoid vitamin A supplementation already early on in CKD. If you would measure it in our CKD patients and dialysis patients, they are often in the high, even up to toxic range, but you cannot do much about it. In case of symptoms who might be related to vitamin A toxicity, I think in that setting I would measure it, but I would not do it routinely. But all patients with CKD who were put on a vitamin preparation will be one without vitamin A, for sure.
And certainly there isn't really dietary management, is there? Because
no.
Other than avoiding this very concentrated source of vitamin A and as you say, supplementation. And indeed, we don't know what the safe level of vitamin A intake is in these children, do we?
No. And it's sometimes crazy how high they are. I don't do it in routine because they are often very high in this, especially in those hemodialysis patients or PD patients, it's often very high.
Thank you. Okay, question here. One of the side effects for lysine is increased absorption of calcium for patients with low calcium. Does anyone use lysine to help increase levels?
Not aware about that. So I don't know if you, Vanessa, but I don't.
No, I'm afraid I haven't heard about that either. I'm sorry, perhaps we need to go away and read about that, but I'm
yes.
that's a new one on me.
Yeah, I agree. Some work to do. Yes.
Okay. Let me just have another quick look here. There seems to be, and there is an element of truth in this, that diet isn't a cause of high serum potassium levels in children. Do you agree with that statement, or does it need qualifying?
It's I agree, actually. There are a lot of non-dietary factors who are also contributing to potassium. Think about metabolic acidosis, who are shifting your potassium to your extracellular compartment. ACE inhibitors are, of course, very known to cause hyperkalemia, and especially if you use them in more advanced stage of CKD, they are very prone to hyperkalemia. But if you think about diet, I think you start with the factors that you can modify in your treat metabolic acidosis. That's where I start for sure. But then if you look to the diet, I think you have to make a distinguish between the potassium sources who are avoidable, then talking about fast food again, all these potassium sources who are more like used in the packaged food. I think these are the ones who are benefit for potassium and phosphate and sodium. So these were the ones that I think I really we need to continue discuss them very carefully and very strict with our patients. But I agree with your statement about the fruit and vegetables, and that's also how we have rewritten our guidelines about potassium, that we are not going to routinely advise against the use of the use of to restrict tomatoes, bananas, and so on. This is something that we have abandoned. So I would say yes about the healthy food, but not about the fast food. I think this is really, I think our focus should be to learn our children eat healthy and avoid all this packaged food with a lot of sources of potassium.
And I think it's important to bring in the bioavailability of potassium in the different food matrices, isn't it? That if you've got plant cell walls there in your legumes, your potatoes, vegetables, fruits, then the bioavailability is going to be much less, isn't it, than if it's potassium chloride or other salts which are added to processed foods. But I think there is one area where potassium intake does directly affect serum levels. That's if a child is totally on a formula, an enteral formula or an infant formula, because that potassium will have 100% bioavailability because it's there as a potassium salt, isn't it? And we know that if we give less potassium in an infant formula, then we see a drop in serum potassium levels. So I think when we're saying diet, we need to distinguish between, is it food, where the food is in a matrix, which is going to reduce its bioavailability, or is it in the form of a salt, where it's 100% absorbed? So I think we maybe need to make a bit of distinction between food and formula when we're talking about diet. That's my personal view.
Yeah, correct. Yeah.
Just one more question coming through here. And this is getting back to metabolic acidosis again. Does chloride have a place to play in metabolic acidosis?
Yes, in our interpretation. So yeah, I found it hard to decide how much detail I was going to give in the theory. I didn't want to give too much detail on one hand, but you're right. So when you're going to assess metabolic acidosis, you will always calculate also your anion gap, and this is based also on chloride. You will have two groups of metabolic acidosis, which can be of relevance in CKD. The first one is those patients with a normal anion gap, and that will be those patients with a higher chloride. So these will have metabolic acidosis with a higher chloride. The other group where these acids are accumulating, these are the patients with a higher anion gap. And those patients doesn't have typically that high chlorides. But in practice, you will have the mix of both. But yes, so chloride is definitely relevant in the interpretation, and especially those patients with hyperchloremic metabolic acidosis with a normal anion gap. Those are the ones who will benefit most of the bicarbonate supplementation for sure. Because these are the ones who have metabolic acidosis because of loss of bicarbonate. Yeah.
And presumably there's no dietary input there with chloride?
No, chloride, no. No, because if you give no, you will not get it better with giving more chloride. You will get it worse. So you need to give bicarbonate. It's chloride who is replacing the bicarbonate somehow, because it's plus and min who has to be in balance. So by adding more chloride, you will not get this better. It's the opposite. You need more bicarbonate, and your chloride will go lower by treating it with bicarbonate.
Excellent, thank you, Evelien. I think that's the end of the questions coming through, and we are just about coming up to the hour. So it's just left for me to thank you very much, Evelien. That was an excellent presentation and a great response to the questions. Thank you to our audience for posing questions and taking part in the poll. So we will end the webinar now, and it's just for me and Evelien to say goodbye to you. Bye-bye.
Bye.